All right, we're ready to start. So my name is Carissa Vandenberg, and I am faculty over in the School of Medicine at St. Louis University. And I am going to talk today about screening, brief intervention, and referral to treatment. This is basically often referred to as SBIRT, and they have been trying to get this as a kind of standard of care in medical settings for quite a while now. Because if we do consistent screening, we're much better able to catch people who may have problems with substance use, kind of more at earlier stages of it, and intervene earlier, and basically get people to just kind of be more aware of the habits that they are beginning to have. So I just, first of all, a lot of this material comes from SAMHSA. And it was basically from a grant from one of my colleagues, Joe Pickard in the School of Social Work. He pulled this together with SAMHSA materials, and he did a lot to make it a great presentation. So we'll just keep working on that. So what is SBIRT, and why use it? Well, by the end of this session, you'll basically be able to define what SBIRT is. We'll give it a little bit of its supporting evidence. It has tons and tons of supporting evidence behind using this tool. And it's just kind of beyond the scope of this presentation. And it also gets a little dull. We also will talk about the value for people who are at risk and who have substance use, and better answer the question, why use this in your healthcare setting? So essentially, want to kind of think about SBIRT as part of a kind of a spectrum of different care approaches that work along the lines of, but also, where we think of universal, selective, and indicative prevention. So really, SBIRT fits into this early prevention before people necessarily have problems, but it also catches people who have problems, and it gets them to consider their problems, maybe just do simple things like cut down, or engage in other types of activities, or do certain types of interventions. It could be behavioral health. It could be other things like that. And then to make themselves at lower risk so they don't continue to have problems. Because one of the issues that end up with substance use is you build a tolerance. So you may engage in this behavior, and at this level, drink your 2 drinks a day. At this level, you become tolerant to the 2 drinks a day. So it's very easy for that 2 drinks a day to turn into 3 drinks. And so because this tolerance is so quick with alcohol, but also other drugs, and that people don't even seem to realize it, it's that when they're at high risk at certain points, we want to really make sure that they don't get at higher risk, so that they are aware and they stay where they are, or they reduce a little bit instead of going up. There's also, when we think about treatment, so if people really have a substance abuse problem, a dependence issue, there are many different evidence-based practices to consider, but there's also recovery supports, which sometimes takes a different track. But these recovery supports are really for people in the long term in terms of substance use. And so essentially, as people are doing the recovery supports and the evidence-based practices, as they get kind of more on the wagon, as they say, we essentially, they rely more and more heavily on these recovery supports in order to stay clean. So SBIRT, lo and behold, basically stands for Screening, Brief Intervention, and Referral to Treatment. It's a comprehensive, integrated public health approach to delivery of early intervention and treatment services. It's focused on people who have substance use disorders. And when we talk about disorders, we're talking about abuse and dependents, and those who are at higher risk. And higher risk, basically, there's high risk levels for alcohol use when people start using alcohol more consistently on a daily basis. And there's and basically anyone who is using illicit drugs is usually considered at higher risk. These types of interventions are basically specifically made for primary care and hospital settings, but they've also been tested and work in other community settings. And it basically provides a really important opportunity to have this conversation because it's short and it fits within a clinical encounter. So, one of the really neat things about SBIRT is it uses a lot of motivational interviewing strategies. So one, it essentially brings up the conversation like motivational interviewing does. And you're basically be able to assess how much people use and how severe their substance use is. So that basically we could figure out where we are first before we even talk about something. Then this basically builds awareness of what the person is doing anyway, because a lot of times people are using alcohol and drugs and they don't really realize how much they're drinking or how much they're doing until you actually ask the question and you lay it out and you see, and they kind of more visually kind of see what they're doing from day to day. The next thing this does is there's a referral to treatment. Well, you can't just say, okay, this is your diagnosis, I'm going to give the referral. It's much more complicated with behavioral health. You always have to have a conversation, almost always have to have a conversation where you're doing a lot more of working with people's resistance to getting help. One of the reasons with substance use particularly, one of the reasons is the substance use makes people feel good. So a lot of times they don't want to give that up. And if they are also engaging it to reduce stress, they oftentimes don't really, they're not aware of other means of coping. So you are in a position where you need to work with this and you have to do it in a short period of time. So here's a little bit of the evidence for why this SBIRT screening works, even though it's just this short, simple thing. Patients actually are quite open to discussing substance use with healthcare professionals. It is something that they, basically about 92%, 96%, and 93% are in agreement or strongly agree that they want the doctor to feel free to ask about their substance use because it's an important part of their health. So a lot of times when we go into screening, there's a lot of different types of screens we use. And I sent these through to the ATSU and the other AHEC center. There should be a bunch of different screenings because we're going to talk about some of those screenings in this conversation. So if you don't have them, please let either Marcy or Cass know about getting these screenings. They will send them to you. And if they don't have them, I'll give them to them. So doing these screenings, most of this is related to alcohol use. And so when we think about alcohol use, when they use a screening like audit, they're going to find that, 40% are at very low risk. They maybe drink every once in a while. 35% start getting at this at-risk use. And this means that they're kind of drinking almost every day. And this is sort of the area, this 35% is where people begin to start getting health issues as a result of their drinking. they may be perfectly functioning in their regular life. Maybe they have a little bit higher depression, but it's not going to be something where they are going to come into work stumbling drunk, or they have what we would consider uh, uh, dependence problems. The issue when people start getting, but what we want to think about here is that we're getting to about 25% who are at the harmful use and dependence use level. And so we really want, this is sort of the group of people that you want to target through this kind of screening, because you really want to catch a lot of these. You want to catch the sort of at-risk use, kind of tell them, you know, tolerance can build up, and you know, the heavy use of alcohol can really affect you in terms of chronic disease, especially cardiovascular disease. Harmful use, you know, this is the group that you want to start thinking about interventions with, referral to care. Because even if they don't go, you know, we're going to probably say the dependent use are the ones that are going to need to get actual substance abuse treatment. But the harmful use probably could use some sort of other kinds of supports to deal with stress, to reduce their need to drink so much, to drink, and to kind of be more careful. So again, these are some of the issues that are related to, you know, kind of being an at-risk use and harmful use. There are a number of issues. So I brought up, you know, heart disease and cardiovascular disease. That's a big thing because, you know, that is one of the biggest killers in terms of chronic diseases in the US and in the world. But US particularly has a problem with cardiovascular disease. Also liver disease. We also have issues with cancers, especially breast, colon, esophageal, head, and neck cancers. You put yourself much more at risk of STIs, generally from using substances. But it also, there's also some other kind of biological reasons that it reduces your ability, your immune system to fight these kind of things. So you're not only at more risk, you're also, your body doesn't fight it as well. Trauma, disability is also another thing that you're at higher risk for, and you're more at risk for negative life events. I mean, just the very fact that when you drink too much, you very easily get to a point where you shouldn't be driving. And, you know, that already it's very easy to get into an accident. So you could take that to other parts of your life and you kind of see the same thing. So this is sort of an interesting chart. It shows that, you know, a lot of problems that people have are occurring among these moderate risk. So I think what's most interesting, we expect that the high risk drinkers and the people that really have alcohol use problems are having problems with aggression and spouse and jobs and friends and accidents and health. But actually quite a lot of these moderate risk drinkers also have these problems. So again, kind of reiterate, this is what SBIRT's for. You know, it's to kind of like intervene, talk to people about the effect of alcohol on health issues and also their, you know, their quality of life. So, you know, actually SBIRT's been around and supported by SAMHSA. SAMHSA is basically part of US Health and Human Services. They kind of do basically fund all the different health programming in the US, as well as social services and mental health programs. And they basically have been trying to get SBIRT programs implemented since 2003. When SBIRT is fully implemented in health systems, it leads to a 40% reduction in harmful use of alcohol, by those drinking at risky levels, and a 55% of reduction in negative social consequences. So it can be powerful. Issue is people need to use it on a system-wide basis, and they have to use it consistently. Again, these are some of the clinics that it's been tested and it works. This is, a lot of this has come out in like 2011, 2012. So there's even more places where SBIRT is used and can be used. So again, one of the things that SBIRT does is because you're asking people when they're at kind of lower levels, it acts as some sort of means of education on what people are currently doing and how their use can affect them in the long term. So essentially, when you just basically have a conversation about alcohol use, somebody may be just drinking a beer every day. It's important for them to recognize the outcomes of that behavior, because it may be seen as no risk among themselves or people around them, but they need to have some understanding of the potential risks. And so they may not necessarily, they think about this consumption differently, and whether it's good or bad, and whether one drink maybe should turn into 2 drinks every day. So it may be that they get to the point where at least they stay the same and say, okay, I have my 1 beer and I know this is not so great, but it's going to be really bad if I go to 2 beers. So this is a typical kind of pre-screen, and this works along. There's a measure in the screening that I provided in with these materials called the audit, and it uses a lot of these. It uses the same kind of thing. So one of the ways that the audit works is you provide a pre-screen. Is one, you don't really want to bother asking all these questions to somebody if they don't drink in the first place. So you first of all just get at whether or not they occasionally drink. So you're kind of building up with this. You don't go out there and say, do you have a problem with alcohol? You don't start that way. You start, okay, do you sometimes drink wine, beer, alcohol beverages? There's nothing really controversial about saying yes or no to that question. Okay, then we build up. All right, how many times in the past year have you had 5 or 4 drinks drinks or more in a day? So this gets at binge drinking. So, in the past year, have you drunken more? So when you're talking to a woman, you say 4 drinks in one sitting. And if you're talking to a man, it'd be 5 drinks in one sitting. This getting at this sort of binge drinking use kind of starts to show where somebody is going to have some sort of risks. And then if they're affirmative, you move to the full screen. So this is the screening to brief intervention. This is one of the types of screen. Past year, how many times have you used tobacco, alcohol, marijuana? And then if they're never, you just don't go any further. If they're affirmative in any way, then you kind of go and you see if it's any kind of significant use. It's also important to think about, how often people drink, and the per day drinking. This is another part of the screening process. Again, we have provided you screens so you can follow the screen specifically. They're very easy to follow, and it'll lead you in the direction that you need to go on these. Important. There's also a little note card in there, and it shows you what 1 drink is, because people can consider one drink. 1 drink of wine is going to be different. So you can't use a glass like that for your wine, or a glass like that for your bourbon. These are all going to be at different sizes, and we start to really consider about ounces when it comes to spirits. So number of shots, people that each shot is a different drink. So people can put multiple shots in one drink. So those are all part of what we consider one drink. And when we start looking at risk, but again, there's a little note card that, and this can be useful when you try to do the screening with patients, that clarifies what one drink is. So, the SBIRT and the screening debrief intervention, this SBIRT one looks really at high risk drinking by looking at binge drinking. So we determine if people are binge drinkers, and then we look at the specifics of it. If they're not engaging in binge drinking, and that means you have a whole year, if there's no binge drinking that occurs, then they're light drinkers, and they're basically, you don't have to be as concerned about them. But this is one of the different screens. So there's one screen where you do this, you test for binge drinking. I tend to like the audit one because I think one of the things, but it is a screen that takes a little bit longer. And the reason why I like the audit one is because sometimes people are engaging in, oh, okay, that's right. Sorry about that. I always forget this. They have the binge drinking, so you test this, but this one also asks this question, which I think is really important. So binge drinking can really show this kind of risk that somebody is engaging in a lot of drinking, at one time, but there's a potential to miss people. And this is why you want to see if people are drinking, 2 drinks a day, that's 14 a week, or if women are drinking once daily, they already start putting themselves in this risk category. So those people, if you do a screening, you should not only consider the binge drinkers, but also these people who drink regularly every day, and they drink, the women, because they're much more at risk, they're smaller bodies, they are going to be at much, they basically, it's 1 a day and it starts becoming not great. The men, it's 2 a day and it starts being not great. So if they have this going on, then that means full screen. We kind of reviewed some of this stuff, but again, evidence behind these numbers is within these limits of, 5 drinks and within binge drinking. When people engage in this level of binge drinking, this is when all these bad things happen, and the risk curves go up. So I'm going to give you some information about some of the screens right here. One of them is an audit, and this is the Alcohol Use Disorder Identification Test. This is 10 questions. This is one of the ones that I think is much better for alcohol use. There's this previous one that I showed you before. This is the screening debrief intervention. One good thing about this is it captures different kinds of substance use, including prescription drugs. The audit, which is in your packet. Did I put it here? Yeah, and it's also right there. It captures only alcohol use, but it does it in a much, you get much more detail about whether somebody really has an alcohol use disorder versus not. And so you can get a better diagnosis for it. Again, the diagnosis has much more validity coming from an audit. As you can kind of see here, the limitation is, again, you can't study alcohol. So this is hard to see, but I could kind of read off some of the questions. How often do you have a drink concerning alcohol? And then people could say never, monthly, 2 or few times, blah, blah, blah. How many drinks containing alcohol do you have a typical day? And this is where you can kind of show a card. How often do you have 5, 6 or more drinks on one occasion? How often do you, during the last year, have you, and it goes on, but there's also other kinds of questions that really get at problems related to drinking, like taking a drink, basically having a first drink in the morning, you know, after heavy drinking. That's a really high risk sign. So you also see here, it's very blurry, but you can see that there's numbers here. And so what you do with this is you add up the numbers from what people do, just like, you know, you're taking a Cosmo exam or something, a Cosmo quiz or something like that. And you can put it, you can see what the score is by the number you have. There's also specific domains in here. So hazardous alcohol use is the first domain, what first 3 questions, dependent symptoms is the second domain. Again, you know, the screening to brief intervention, which I showed earlier, doesn't get at dependent symptoms. And then the harmful alcohol use is, you know, the guilt after drinking, alcohol related injuries, other concerns of drinking. And so this, I'm sorry if you can't see it as well, I'll move that. So you see this, if people get a score of 0 to 7, they don't need to be worried about. They get a score of 8 to 15, these are the at-risk groups. So these are the ones, the health issue group, where you start to kind of talk about reducing the amount they have. This is the harmful use group. So this is the one where they're abusing alcohol and they're causing a lot of problems for themselves. So this is a time to get people connected to behavioral health, 12-step groups. You may consider outpatient alcohol use treatment as well. And then the dependent use group, this is definitely where they consider inpatient or outpatient treatment. And again, you have to get a score of 20 or more to get to dependent use. Harmful use is 16 to 19. So there's a range there of behavior. So you're probably asking, well, what about drug use? I mean, we have a lot of patients that use opioids. I want to be able to test substance use as well. Well, another screener we have is the DAST. And the DAST is a shortened version of a longer screener, which is 28 questions. And I have to say, you know, these questions actually go pretty quickly because they usually make them yes, no. So you actually speed through them in a few minutes. It essentially, the DAST has screening questions about drug use that is very similar to another screener that's used for alcohol. It has a sensitive screening tool for at-risk use, but again, you have to use a separate one than the alcohol use. So this could be something where you start with the screening to brief intervention one and have it for the first few questions. If you see an issue with drug issues, then you do the DAST. If you see problems with alcohol, you do the audit. If you want to have a full screen and a true diagnosis. So here's the DAST questionnaire. Have you ever used, this is easier to read because there are fewer questions. And they're all yes, no. So it makes it pretty simple. Have you used drugs or other than required for medical reasons? Do you abuse more than one drug at a time? Are you able to stop using drugs when you want to? Have you ever had blackouts or flashbacks? Do you feel bad or guilty about drug use? Does your spouse or partner complain about your involvement with drugs? Have you neglected your family because of the use of drugs? Have you engaged in illegal activities in order to obtain drugs? Have you ever experienced withdrawal symptoms when you stopped taking drugs? And have you had medical problems as a result of your drug use? So we see that it goes into some of these different domains that the audit did. Not quite as many. So you see when you ask fewer questions, you can get less information, but it does give you a good sense of whether somebody has a problem and what stage you need to get them involved in treatment. Again, here you do the same thing with scoring, except yeses is a 1 and no is a 0, and then you just add it up. So if they have a 0, then they don't have any problems. If they have 1 to 2, they're low level problems. So you really want to monitor them and keep them close to you and assess at a little rate and tell people it's dangerous what they're doing, but just try to do it as little as possible. Moderate level is when you want to start. With substance use, we really start getting with illicit substance use, you really start getting more involved at the moderate and the substantial level, because addiction for some of these substances is faster to get addicted than others. Again, this is a different, they even consider hazardous use at 1, 2, because you could use something like heroin or methamphetamine and it has fentanyl in it and you could die. So it has a much lower bar for any kind of illicit use. So key points on screening: screen everybody, screen both alcohol and drug use, if you can, including prescription drug abuse and tobacco. Use a validated tool. So there are quite a few different tools. You basically can just look up substance use valid tools, NIDA, and there's actually a matrix of different tools you can choose from. The ones that I'm talking about in this presentation are the most common ones, but there's other ones if they fit your needs and they're validated and they've been tested, over and over again. So pre-screening really should be part of general wellness. And when you do a general wellness visit, if you can explore each substance, or the more substances that are explored, the better. So you can kind of get a broad view. When you have red flags, follow up with them. Get details, consequences of health, wealth. With these people who are red flags, you really need to engage in a conversation about substance use. This is also where the motivational interviewing skills become really important. You want to be non-judgmental, you want to show empathy, you want to be, and this non-judgmentalness and empathy, you can do this through nonverbal behavior. You don't have to think of the most clever way to say things, but it's also just reducing the level of arrogance. Sometimes that's something that a lot of us have to work on, especially when we get into health professions and we see that we're able to pull off things that seem magical. It can kind of hit at our egos. So this sometimes rubs off to patients, and it's something you got to watch, especially for those patients who are in very stigmatized groups. Screening is the first step for the process. So we can't really treat people if we can't screen them. And it basically, this allows the provider to determine a course of treatment. So one of the things that we're going to talk a little bit about, and I'm going to, in a few slides, I'm going to show you a video as an example, because this is something that maybe takes a little bit of training, but I think you can get a sense if you watch some videos of how these types of brief negotiated interviews work. So these are kind of part of motivational interview framework. They just keep thinking of shorter and shorter ways of doing it, right? Because it has to fit into this clinical encounter. And really what these are these semi-structured interviews where you're framing the discussion essentially, and you want to try to keep them within 15 minutes. So the first thing you do, steps for a brief negotiated interview, is you build rapport, and you raise the subject. How do you raise the subject? Well, I got to do the screen. And then you get the answers from the screen. And so once you have this information from the screening, this gives you an opportunity to explore the pros and cons of the behavior. So this pros and cons, kind of balancing of pros and cons is a really kind of important aspect of the motivational interviewing approach. It gets at being non-judgmental, where you really try to get the person to talk about this from their perspective. But this also, once you let the person talk about this from their perspective and go into where they think this helps them, and then also talk about where they may have some problems and how it individually affects them negatively, you get a chance to give them some feedback. Once they feel heard, they're more willing to hear from you. And then once you do this feedback, the feedback is kind of a small part of it. The bigger part is getting people ready to change, and they may not be ready just yet. But you can come up with some type of plan and negotiate some type of plan for them to do something that reduces the risk. One other thing to think about here is, and this is a question for all of you, maybe you can put your responses in the chat box. Ooh, there's lots of people here. Oh, people's names are in there. Okay. One question is, what if a patient does not want to talk about his or her use? Does anybody have a thought on that? If you're paying attention, I know somebody's got to be thinking this is just riveting and fascinating.
I can try to chime in.
Oh, somebody, yes. Maybe say your name and tell us, what do you think, does what if a patient doesn't want to talk about this? What do you think you should do?
Honestly, in my opinion, like, if they don't want to talk about it and you can see that, I would just try to like go at it from a different angle. Just reveal things about myself, not necessarily, anything bad or anything, or if I did anything bad, but just try to emphasize with them and just try to just let them know that you truly do care and you truly do, want to help. So by you opening up to them, that may make them want to open up to you a little bit more. I don't know. It's just my little 2 cents.
Well, so this is an interesting way of thinking about it. So it really depends what you are, what type of health professional you are, right? So if you're a peer support person and you're doing peer support, and you're saying, look, I had a substance use problem and I had this real problem, sometimes that can be helpful. And if you have a peer support person on staff, that can be helpful in getting this conversation started. But when you're a behavioral health professional, a lot of fields want you to reduce the amount that you actually talk about your own life. Because sometimes that can get you into trouble. And it also makes sometimes this therapeutic encounter about you instead of them. Does that make sense? So one way to approach this is, if they don't want to talk about it, you could say, well, this is an issue that relates to your health. We can do the screen, but if you don't want to do the screen, we don't have to. Because really it is the patient's right, and they have self-determination to not get the screen. So you don't have to necessarily push it on them. You don't want to, because part of this building rapport is you move with the patients. They're voluntary. They're not required to be there. And so if it doesn't work out and you can't get them to do the screen, then they don't do the screen. It is what it is, right? But again, if you build this rapport, they may feel more comfortable to come to you later. I think we kind of talked about this. We touched on this. So pros and cons, a little more on doing pros and cons. One thing is, there's a number of different open-ended questions that exist that you can just kind of like write down and have on a list related to pros and cons of substance use to ask people. But a lot of times what will happen is people will kind of give you a little bit of a laundry list. And if you're listening very closely, you can come up with much better questions. You want to make sure when you ask these questions, they're open-ended, that they don't answer yes or no, because you really want them to convey more information and engage more. The idea is once they have put this emotional energy into this conversation, it just kind of keeps this cycle going. One way also when you're doing this is to really show that you're listening. A way to showing you're listening is to do some type of reflective listening. This is basically like when they're saying something, you could just say, oh, this is what I seem to have heard, and you summarize what they say. And then you basically, within that, you encourage them to say more about it. So pros and cons is useful because this reinforces what has been said, but it also shows that you're carefully listening. When you're done talking about pros and cons, you want to summarize what you heard. So this is what I heard. These are the pros and these are the cons. Is this right? And then providing feedback. This is all, you really want to keep this patient-centered. You want to let the patient lead. So, basically ask permission to give feedback. Then discuss screening findings. So, they can have the pros and cons, but in terms of, information, once you've got into that conversation, they're generally going to say, yes, I want to hear some more information about the screening findings. But it also is, it also allows you to when you're giving this feedback to talk as a health professional, or if you're a mental health professional, as a mental health professional, what the known consequences to drinking are, or substance use, so that people are clear and you as a health professional are giving them this health information. If you get to a conversation about change, one thing to think about is this is a good way of bridging the thing. Could we talk a few minutes about your interest in making a change? What do you do if they say no? Well, then, okay, you basically push back and you make it clear that if they need to talk about this further or want to talk about this further, you're here for them, but otherwise it's really something on their part. And really, we want to think about this in terms of health professions, how much we have control over, and what's on our side of the street, what grass we got to cut, and what's on other people's side of the street. And there's only so much control we have. We're seeing people for 15 minutes or 20 minutes or an hour. And they have this whole other life outside of it. So you want to be a place where people feel comfortable to come and talk. You don't want to make people feel like they have to please you in a certain kind of way, because they already have to please their boss. They already have to please their spouse. It is more important that they come to you to get a service and the help they need. So this scale is a useful way about looking at readiness to change, because it kind of can stimulate a conversation on a scale of 1 to 10, 1 being not ready at all and 10 being completely ready. How ready are you to make any change for your substance use? And then you can talk about that a little bit more. So what do you think? Tell me more about why you answered 6. What are some of the problems? What are some of the reasons you think you can change? And you negotiate a plan. And when you're negotiating a plan, it helps for you to know about what resources there is that are out there for people. You don't want to try to negotiate a plan if you don't know anything, because it irritates people. There are high expectations when we go into health centers that people are aware of how to help. So that's what I have for slides. I'm going to show you a short little video, and then we can open the floor for questions. So if you bear with me.
Okay, so if you don't have any more questions about your hepatitis C diagnosis, I wonder if we could switch gears and talk a little bit about those screening forms you filled out, about your alcohol and drug use. I'd really like you to tell me just in your own words what a typical week of drug and alcohol looks like for you.
Well, I don't know, maybe around noon, a few beers, and as the afternoon goes on, we're to vodka or whiskey, whatever's available. You know, I guess a typical day could be anywhere from 10 to a dozen drinks. To be honest, I don't really count.
It's hard to keep track.
But pot or Adderall, maybe 3 or 4 times a week. It just depends on, what's available, who's got something to share.
So it sounds like you're using drugs about 3 or 4 times a week. And you're drinking, I think you say about 10 drinks on an occasion?
10 or a dozen.
Yeah. Okay. And that really kind of fits with what you reported on the screening forms. What I'd like to do, if you don't mind, is tell you a little bit about what's on those screening forms and what they told us. Would that be okay with you?
Yeah, sure.
Okay, great. So your score on the alcohol use screening form was 25, and a score of 14 or more puts you in the highest zone, or zone 4, or severe, as we call it. And what that means is that your drinking is at a level where you're experiencing some significant consequences and could benefit from additional assessment and assistance. I actually have this little card here that can sort of help show people where their risk levels fall. And so if you look on this, there's a pyramid, and you can see zone 4 at the top, and then the lowest risk zone where most people fall, you can see is zone 1. And to be in zone 1, you'd have to have no more than 4 drinks a day and no more than 14 drinks in a week.
Oh, geez, I got that beat in 2 days.
Yes, and that kind of fits too with your drug use, which fell also in the harmful zone, which again indicates you're experiencing some significant consequences from your drug use. So, given all that, I'm wondering what do you think about your drug and alcohol use?
Well, I know I've been drinking more lately, and I do know my mom and my sister have been worried about it, worried about me.
Yeah, so you've noticed some sort of effects with your family relationships.
Yeah.
And do you see perhaps any other connections between your drug and alcohol use and other issues in your life?
Yeah. I knew I missed work a couple of days just because I was too hungover to get out of bed. And cost me my job. And now I'm couch surfing among friends. I mean, I've got a buddy who's been kind enough to let me stay with him for a while, but he's saying it's pretty much time to move on.
So you've noticed that it's affected not only your family relationships, but it's also had a big impact on your work life.
Yeah.
Okay. Your drinking puts you in the severe zone, and your drug use is putting you in the harmful zone, indicating that you're having some significant consequences from your use, and that you can benefit from some additional assessment and assistance. And I'm certainly concerned about you and your use. And it sounds like you have some concerns too. It's your family life. It's really affected your work. And I know earlier you were talking with a nurse practitioner about how alcohol use can really severely affect somebody with hepatitis C. So given all that, what I'd really like to do is refer you to some more specialized services where they can more sort of fully assess your situation and figure out how the best they can help. And so I kind of wonder how open you are to something like that. Actually, I have this little ruler here, and you can see it has a scale from not at all 0 to 10, which is very. And So how ready are you to perhaps go see somebody to get some help with your drug and alcohol use? What number would you give yourself on this scale?
I don't know, maybe a 6.
Okay, so you picked a 6, which indicates that you do have quite a bit of readiness to talk to somebody. What made you pick a 6 and not a lower number?
Well, I know I can't keep going at this rate.
Something's got to change.
Yeah, but I don't want to be locked up in some rehab clinic or anything like that.
Okay, so you don't want to be forced to do something you don't want to do. And so why don't we take a second to talk about what the pros and cons of getting help would be? And that sounds like one of them. What other concerns do you have?
Well, not getting a buzz when I want to.
Getting that escape is important to you.
Well, my life kind of sucks right now.
So it's what's giving you sort of both relief and enjoyment.
It's the only thing that's giving me enjoyment right now. And what's not working, I mean, I don't know how I'm going to be able to afford treatment.
Okay, so let's switch gears now and talk about the other side. What would be some of the good things of getting assistance?
Maybe just get back to work, get on my feet, get my mom and my sister off my back, that sort of thing.
Okay. So you're talking about some pretty substantial changes that would turn your life in a very different direction, make a pretty positive move forward.
Yeah.
Okay. I can see that you're kind of grappling with on the.
All right, so I think we kind of have a good idea. I'm hoping that this gives you a sort of a good idea about how to do these different brief interviews. I just put a link for the videos in the chat, so you can complete that video and finish watching it if you want to sort of get a better understanding. But there's also several more, so the other videos also get at different levels of use as well, so you could get a sense of what this intervention looks like in real time. We have a couple more minutes. I'm going to leave it open for questions, but if you can get started on the Qualtrics again and do a follow-up for this, if that would be great. Marcy, is the or Cass, is the follow-up link the same as the first one? Well,
we just did the pre-test. We didn't do the post-test.
Okay, so maybe just do the pre-test a second time.
Okay, I'll put the link in the chat again for that.
Yeah, I mean, essentially we'll be able to see that you did this after. So we'll get a sense that before and after. And if you can maybe, are they writing names in there, or I don't remember how it was done.
I can't remember if the names were in there or not, but I know that there's a, I'm not sure if there's names in there or not.
Okay, if you can write somewhere post-test, that would help, but otherwise we'll just check by the time. All right, any questions? Okay, well, nothing? Didn't even make a mistake somewhere that somebody's completely confused? Come on, tell me, is there anything? Well, anyone have any comments or anything to talk about? Oh, well, somebody liked it. Thank you.
Hi, my name is Dr. Bashir. I'm a first-year family medicine resident. I really enjoyed the talk and the topic. I think it's very, very relevant and pertinent. I liked how you presented the data to back up the use of the screening tools, and I'm looking forward to implementing some of these to use on a regular basis. I guess I just didn't realize I mean, I typically ask my patients about alcohol and drug use. Like the medical students who have been with me, they know that I ask them that. It can be uncomfortable, but I like that the data that you showed said that they do want us to ask that, and they would answer honestly. So that makes me feel better about doing it. And also, I just didn't realize that it was such a significant problem. So this was very insightful.
Thank you. Thank you. Well, and also you can get CME credits if you need this. So let me know if you need them.
Thank you.
Yes, and in the survey at the end is Carissa's name and email in case if anybody has any questions or wants CME credit or anything like that. It's included in that survey at the end.
I guess my question would be like, so I know like at our clinic, I don't know how it is at other clinics, but typically we screen for depression. So if it's something that you see that or would anticipate that we do like across the nation, like how we're starting to screen for depression at each visit, like would we be doing this screen at each visit? Is that the goal?
That was the goal. And that's where when SAMHSA was trying to get SBIRT fully implemented, that was where they were trying to go. And my guess is there's probably some kind of screening documentation in the EPIC forms that the hospital already has that you can just use. But you can start off with just basically seeing if they use in the alcohol or drugs in the first place, and then getting at how often they use. And then it can lead you to just doing any of these different types of screens. And I think we also have all the screens that I recommended were sent to everybody as well. So you can just kind of look for which one you feel that you just like the most. It's going to be the easiest to use. Oh, okay. Well, it's 1:02.
Wait,
It was great.
where were those sent? Because I did not receive them.
Marcy and Cass, did you send that? I sent a whole bunch of I sent the PowerPoint and a whole bunch of the screening materials, and also some of the sort of like tools to use this stuff with.
Yeah. So Dr. Bashir, you said you're in Kirksville?
Yes, and maybe I might have just missed the email, but I checked the email with the Zoom link and I didn't see attachments on it. So maybe there was a separate email.
Debbie Dar should have them.
Okay, I'll reach out to her.
That would be great. And I'll email her and ask her to send them out to all of you guys as well. She did forward it, but it was a separate email from the link. So maybe she just didn't get the attachments forwarded.
Okay, thank you so much. I really appreciate it.
All right. Well, thank you, everybody, and have a good afternoon.
Thank you.